One of the most scary times for me is when a patient's on something I know that is likely to cause birth defects, and they stop taking their birth control pills, or they just do something that's just not good judgment. That's kind of my nightmare, and I've had it happen several times. You tell them not to do that, and they sometimes just don't listen. So far, knock on wood, the few situations where there's really clearly been a high risk, things have worked out fine. So for first-generation antipsychotics, they serve as antagonists at 4 major neurotransmitter receptor systems. They have dopamine type 2 receptor, and that's associated with EPS, the nigrostriatal dopaminergic pathway. You have the muscarinic cholinergic receptor, the M1, and it's associated with dry mouth, xerostomia, blurred vision, mydriasis, constipation, urinary retention, sinus tachycardia, prolonged QRS interval, confusion, impaired cognition, paralytic ileus, and exacerbation of open-angle glaucoma, and drowsiness. Alpha-adrenergic receptors, alpha 1 and 2, they're associated with orthostatic hypotension, QT prolongation, and reflex tachycardia, dizziness, and incontinence and sedation. Then you have the histaminic receptor. It's associated with sedation, drowsiness, and weight gain. A lot of the studies are only a few months to get those rates. Suggest actual could be double. Yeah, it's true. The endocrine effects, yes, anticholinergic. As soon as you say dry mouth, you know you're talking about anticholinergic. Did that answer your question? Yeah, I think it did. It's a muscarinic blockade, so it's anticholinergic. Endocrine effects, you get the hyperprolactinemia, high risk for promazine, methylridazine, pyridazine, fluphenazine. Moderate risk is fluphenazine, fluphenazine, persine. I forgot even how to pronounce that. Trifluperazine. Perazine, yeah, that's it. Low risk, haloperidol, loxapine, melodidine, pimozide, and thiozanthine. Yeah, that's it. Probably haven't said those in a long time. Weight gain, risk factors, chlorpromazine. You can see the risk factors for each of these, and you can just go down the line and figure out who's the greatest risk. And it's not important that you memorize that, so we'll kind of move ahead on this one. Screen and monitor in a familiar way in a manner similar to the secondary generation antipsychotics. Personal family history, obesity, diabetes, high cholesterol, BMI, fasting blood glucose levels, fasting cholesterol levels, fasting triglycerides, monitor for signs of elevated serum prolactin level. That's what you do for the older generation. Yeah, we got all that. Went over all that. Those are first generation. More first generation. And then we have the cardiovascular effects. Orthostasis. Oh God, this drives me crazy. I've got that wrong. I gotta go backwards. Sorry. So we're talking about the first generation, okay? And I think, yeah, we just did this. And then we go one back. Orthostasis, high risk. It's rather crazy. Chlorpromazine, mesoridazine, dioridazine, and so on. Low risk is a haloperidol. Tachycardia, only chlorpromazine, mesoridazine, and pyridazine have moderate risk, so that's a unique one. Cardiac arrhythmias, dioridazine has moderate risk. ECG changes, QRS and QTC prolongation, only chlorpromazine and pyridazine with moderate risk. So you don't want to give those two particular drugs to people with sick hearts. Practical considerations, baseline EKG and serum potassium and magnesium levels and periodic reassessment. Assess blood pressure at every visit and obtain baseline prior to treatment with elderly patients. The ocular effects, you can get this lenticular pigmentation. All FGAs have a low risk. Pigmentary retinopathy, only pyridazine has that. Practical consideration, monitor for early symptom of poor night vision and secondary nocturnal confusion. What are the hematological effects of these first generation antipsychotics? Both transient leukemia and agranulocytosis has been reported. Similarly, although rare, thrombocytopenia, hemolytic anemia, and pancytopenia have been reported. Practical consideration, baseline CBC with differential, monitor for clinical signs of infection, bruising early in treatment, and repeat the CBC with differential as indicated and annually. So pre-treatment, here's what you do with the first generation. Ames, urine pregnancy test, CBC with differential and platelets. Chem7 panel, this is what a Chem7 panel is, by the way. BUN creatinine, electrolytes, you got 4 of them, and glucose. So you're getting electrolytes, you're getting the kidney, and you're getting glucose. That's why you have to do the liver transaminases separately. However, if you ask for a comprehensive metabolic panel 12, you'll get all that. Lipid panel is going to give you a breakdown of your cholesterol, TSH and T4 annually. The EKG, you want to do that with dioridazine and mesoridazine. Do not prescribe if the QT prolongation is greater than 450. That's a cutoff. Potassium and magnesium, you might want to check that for those two particular ones and get the blood pressure and BMI with each visit. So you take the Ames so for adverse monitoring, when you're monitoring for problems, you want to do the Ames every 6 months with these first generation. And you want the urine pregnancy test as clinically indicated, the CBC with differential and platelets annually. And you also want to do the chemistry 7 panel, SMA, the liver transaminases, lipid panel, TSH. So these are being done. The eye exam annually, especially for the chlorpromazine doses of greater than 2,000 and the pyridazine doses greater than 800. And then you want to do EKG periodically during the course of therapy as clinically indicated. Potassium and magnesium periodically during course of therapy as clinically indicated. Sorry about this. Every time I click them, it's always interesting what's going to come up. Adverse effects monitoring continue. With fever and rigidity and diaphoresis, get a WBC count and a CPK because you want to rule, the CPK will help you rule out the neuromalignant syndrome. Always remember to do a CPK if you suspect that. With pruritus, itchy, or signs of jaundice, you want to check the liver out, so you get a liver panel. Some clinicians recommend annual LTS. With seizures, polydipsia, you want to do EKG, look at the electrolytes and check their fasting glucose. With galactorrhea, amenorrhea, look at the prolactin level. And then with BP and pulse during dosage titration, you want to look at chlorpromazine and pyridazine as factors. Mood stabilizers. So we get to talk a little bit how do we monitor mood stabilizers. So with lithium, valproic, carbamazepine, oxcarbazepine rather, Lamotrigine and topiramate or Topamax. So what do we do? With lithium, we've got to look at endocrine effects because it can decrease serum thyroxine, leading to hypothyroidism in 20% of the patients, women greater than men, treated chronically. 30% will develop elevated TSHs. A very few well-known goiter with normal thyroid studies except for they'll show a goiter with normal thyroid studies except for the elevated TSH. Thyroid issues typically arise 2 weeks to 6 months after starting lithium. Rare elevation in parathyroid hormone and serum calcium level. Practical considerations: obtain TSH and T4 at baseline 2 weeks, 6 months, and then yearly. Hypothyroidism is not a reason to consider discontinuing lithium, but a different agent could be considered. Baseline calcium, phosphorus levels with one follow-up after 6 months in with lithium is prudent. So that's renal effects. Lithium causes polyuria and secondary polydipsia. Glomerular dysfunction is rare at therapeutic dose levels. Renal tubular effects are fairly common. Polyuria is about 60% of patients receiving long-term maintenance treatment. A few will develop severe renal diabetes insipidus with urine value up to 8 liters per day. Results in difficulty in concentrating the urine and maintaining adequate lithium serum levels. Edema is usually not due to a change in renal function and may resolve spontaneously. Practical considerations: you want a BUN and creatinine should be assessed at baseline 2 weeks and then yearly. If creatinine rises abruptly, hold the lithium and check creatinine clearance. Consider discontinuation of lithium therapy. Reduce polydipsia, polyuria by giving most of the lithium dose at bedtime and reducing the total dose by 20%. Unfortunately, I had a patient that I inherited. He'd been on lithium for 30 years. He was doing fine, but then he started going into kidney problems. We started seeing some kidney problems. And so I had to take him off of lithium. It was tough because it worked extraordinarily well for him. And we managed to get him on something else, but it was not without a whole lot of worry and apprehension and some rough roads for about 3 months. But he's doing fine now. Okay, should standard treatment for hypothyroidism like thyroxine work with lithium caused hypothyroidism? You're asking me what specific, when are you asking specific of which form of thyroid you would be giving them? See, I wouldn't be treating that. I would basically get them over to the endocrinologist and let them start and set it up. Oh, just to counteract it? No. You mean prophylactically give them thyroxine? No, because you'll shut down their production. That's what will happen if you give a thyroid medicine early, thinking that you're going to prevent the problem from occurring. All you're going to be doing is just kind of shutting your own development of the drug, actually shutting down their thyroid independently, because they're going to get too much, and it's the TSH is going to have to drop, and so the thyroid won't be producing as much. Just if you counteract it. No, just if you can counteract it. No, you can't. You can't. There's no way to do that I know of. It just happens, and it happens, and you deal with it, okay? But the thyroid issue is not nearly as bad as the kidney, because the kidney, when your kidneys fail, you're in serious trouble. So there's a bigger reason to stop. Okay, you can also, but what if detected iatrogenic hypothyroidism? You mean if you detected it right away, is that what you mean? And then try to intervene? Yeah, you would go ahead and you could give them some thyroid at that point. Yeah, if you've already done it. That would be reasonable. But again, it's a little bit touch and go. There are all kinds of controversies about thyroid. So again, if I thought their thyroid was really a more sustainable problem, I'd probably still get them to one of the endocrinologists to look at it and see what they think. What would be best? Okay. So we have some hematological effects associated with. Would that not be a referral to an endocrinologist? Yeah, that's what I would do. Yeah. Hematological effects, mild leukocytosis, typically in the 10 to 15,000 range, so you get a little drop, increase rather. Practical consideration, CBC or differential should be taken at baseline. It tells you where you are. Cardiac effects. You get a little T-wave flattening, inversion, sinoatrial node dysfunction, bradycardia, rare ventricular premature contractions. Practical consideration, obtain baseline EKG for patients over 50 or with a history of cardiac symptoms, concomitant use of beta blockers or calcium channel blockers. Check potassium and T-wave flattening present, usually not due to low serum potassium levels. Monitor pulse periodically and avoid co-prescription of other drugs that cause arrhythmias. EKG yearly and as clinically indicated. So what do you do for these pre-treatment evaluation for lithium? CBC with diff, SMA, you want the SMA7, serum calcium, and parathyroid. The thyroid screening, TSH and free T4. Usually TSH is more than enough. That's all you really need to get. EKG in those over 50 or with pre-existing cardiac status. Pregnancy test of beta HCG, if it's a female, obviously. In potentially childbearing women. Category D, Epstein anomaly during the first trimester, so we want to watch for that. And get a BMI, always get a BMI. Therapeutic monitoring. Monitor trough plasma levels, 12 hours. Post-dose, after 1 week, steady state level is reached in about 5 days. Half-life is about 24 hours. After day 1, the level is 50%. After day 2, the level is 75%. So yearly or as indicated, dosage changes, clinical or compliance issues, or new side effects. Level won't change after they reach a steady state levels unless there's outside factor contributing. Acute treatment level is about 0.8 to 1.2 millimoles per liter. Maintenance level is preferred to be lower than that. It's 0.6 to 1.0. So here are some definitions that you might want to keep handy. Mild toxicity is 1.5 to 2. Develops gradually over several days. Symptoms include ataxia, the coarse tremor, the confusion, diarrhea, drowsiness, fasciculations, those are muscle twitches, and slurred speech. Then you go into moderate to severe toxicity, which is 2 moles. May result in coma with hypertension, muscle tremor, hyperextension of the limbs, pulse irregularities, hypertension or hypotension, EKG changes, peripheral circulatory failure, epileptic seizures, and acute tubular necrosis leading to kidney failure. May also present as a catatonic stupor. Death frequently arises with values greater than 4. Here's Depakote, Depakine, sodium valproate, Depakote ER, which is my favorite type to use because you can give it all at night. Adverse effects, GI effects, you can get hepatotoxicity, elevated transaminases occur, and about 20% being treated with valproate. Usually benign, dose-related elevation of transaminase levels, not necessarily associated with hepatic dysfunction. Fatal cases have all been neonates receiving multiple anticonvulsants, particularly barbiturates. Children younger than 2 years appear to be at the greatest risk. Monitor clinical status for anorexia, nausea, vomiting, malaise, and jaundice. Practical consideration, liver function tests should be assessed at baseline 2 weeks and then yearly unless symptoms of hepatitis appear. If transaminases are 3 times normal and if levels of bilirubin or alkaline phosphatase are elevated, hold the valproate and consider an alternative agent. The GI effects, you're going to get weight gain with lithium. With valproate, excuse me. So, where are we going? Jump too far ahead. Weight gain. As much as half of the patients will reveal significant weight gain of greater than 5%. Practical consideration, most common reason for why patients discontinue valproate. Monitor BMI at each visit. Monitor fasting glucose and lipid profile as clinically indicated. Exercise and fat sugar reduction occasionally prove helpful, but the weight problem may be refractory. You can also get a pancreatitis with it. Can occur after varying lengths of exposure. Typically presents with abdominal pain, elevated serum amylase levels, usually resolved with drug cessation. Practical consideration, rare occurrence, but high enough for you to consider if clinical symptoms are present. Assess via serum amylase if clinically indicated. So we want to look at the other effects, which include, did I miss something? I think I did. I think this is it, platelet abnormalities. Yeah. So we can get platelet abnormalities. So you get thrombocytopenia, may be seen in about 13 to 54% of the patients. Significant cases are rare, but risk is greater with the elderly. The platelet activation can also be present, but it is a rare occurrence. Usually not clinically significant, but some patients may have substantial drop in platelet count and are increased bleeding time. Practical consideration, warn the patient to report easy bruising or bleeding. CBC after 2 weeks, then 6 months, then yearly, unless easy bruisability appears. Remain more vigilant with the elderly. Drives me crazy. You can also develop these polycystic ovaries. A study of 238 women taking valproic acid. 43% developed polycystic ovaries. 17% had elevated testosterone levels. Among those started by valproic before age 20, 80% revealed polycystic ovaries. So it's obviously worse in younger women. Obesity may play a role in this study. Over 50% were obese. Obesity is a significant risk factor for polycystic ovaries. Finding has not been consistently replicated, but there does appear to be a small increased risk with polycystic ovaries. Practical consideration, out of an abundance of caution, avoid using valproate with adolescent females. Monitor females who are taking valproate for the development of weight gain, hirsutism, menstrual irregularities, and acne. Pre-treatment assessments, here's what we do. CBC, including platelets and differential, liver function, fasting glucose and lipid profile, urine pregnancy test. High neurotube defects, 5 to 9%. Therapeutic monitoring, level at 1 week, changing dose or adding and deleting or other potentially interacting drug. Steady state is reached in about 3 to 4 days, half-life 9 to 16 hours. The levels thereafter drawn yearly. Recommended plasma level, anticonvulsant level is 50 to 100. Anti-manic effect levels 50 to 125 up to 150. Adverse effects, monitoring repeat CBC with differential platelets and LTFs at 2 weeks, then 1 time per year unless otherwise clinically indicated. Repeat lipid profile annually. So carbamazepine, Tegretol, Carbatrol. You get a hematological effect, relative leukopenia without a drop of electrolytes, usually transient and evident during the first few weeks of treatment. Frequency is about 7% for adults and 12% for children. Patients who run low white counts and baselines have a greater risk for developing significant leukopenia. The drop in WBC to 3,500 are not uncommon. Practical consideration, if the differential is normal and is greater than 1,000 polys and the patient is benefiting from treatment, continue with the carbamazepine. High-risk patients should be monitoring frequently during the first 3 months. If the WBC drops to 3,000, consult the hematologist before continuing. Hepatic effects, usually benign elevations in liver transaminases without hepatotoxicity. The GTT is frequently increased up to 100%. It occurs in about 10% of the patients. Not a cause for concern unless the level is more than 3 times normal. Practical consideration, monitor clinical status to rule out malaise, vomiting, and jaundice. If transaminases are elevated 3 times or more, or if the levels of alkaline phosphatase or bilirubin are elevated, hold carbamazepine and consider an alternative agent. Monitor the LFTs at 2 weeks, then yearly unless symptoms of hepatitis appear. So pre-treatment assessment, CBC including platelets and differential, SMA7, TSH, and a T4. I'm not so sure about the T4. The TSH is usually sufficient. The EKG in patients with over 50 years of age or with cardiac disease, AV block, reflex tachycardia, or chest pains. Urine pregnancy test is clinically indicated to category D for craniofacial defects, developmental delay, and neurotube defects. Why do I have to do this every time? It's driving me crazy. Therapeutic monitoring, level 1 week. After starting, changing the dose and adding and deleting and other potentially interacting drugs. Half-life is about 8 to 60 hours. Level 1 month, then yearly. Because of auto induction level at 1 month is useful, but no further induction is expected thereafter. Recommended plasma level is 6 to 12 micrograms per milliliter as an anticonvulsant. Because it induces its own metabolism through 3A4 substrate and inducer, initial levels may drop during the early phase of treatment. That's something you need to remember. This is important, requiring an upward dose adjustment. Adverse effects monitoring, repeat CBC with differential and platelets, LTFs, SMA7, and TSH and T4 at 2 weeks, then yearly unless there is otherwise clinically indicated. Okay, Lamictal. Big issue here is the dermatological effects. If this benign rash, approximately 10% of the patients develop a new onset rash within the first few months of treatment, typically maculopapular in appearance. Some may evolve into more serious rashes. Severe rashes, such as the Stevens-Johnson syndrome, is life-threatening, and the frequency is less than 1 in 1,000 adults and 1 in 100 children. The risk of rash appears to be increased when the dose of lamotrigine is titrated too rapidly or when it is added to valproate, which doubles the serum of lamotrigine. The practical considerations: be able to recognize the hallmarks of serious and life-threatening rashes. One or more of the following. This is a whole list of them. I'm not going to go through that. You can look at that. Warn the patient. That's a big issue. During the first 3 months of therapy, avoid new food or using new deodorants, detergents, cosmetic, fabric softeners, as well as avoid excessive sun exposure because it could confuse the picture for you. Anyone with a rash accompanied by systemic symptoms such as fever or discomfort in the mouth, the eye, or the bladder should be instructed to discontinue the lamotrigine and go to the emergency room as soon as possible. Patients without systemic symptoms should be advised to seek a dermatologist. Patients who develop a rash while taking lamotrigine may very well have a recurrence of the rash while re-challenged with the drug. Okay, hang on one second. Okay, has anyone seen the rash from Lamictal? Yes. There are pictures. If you go online, you can actually see them. There are different types. But as a general rule, if your patient has a rash, what are you going to say? What would be the safest thing to say? Stop. Right. Move on to something else. Right, exactly. Not necessarily go to the ER if it's just a small rash. If you stop them and catch them early. Some of these are benign and they're not going to be a big issue. If you have fortunately we have some real friendly dermatologists that I can send them to, and they'll see them within 24 hours. Just to take a look to see if there's anything necessary to do. They're better at telling you that than I would ever be, or anybody else would be, even a general practitioner. So that's what I prefer to do. If I see something, I'll tell them to stop. And if it's large enough, I'll say go over to the Frederick's office, and they'll see you and check it out. I'd rather do that than to just assume things. Plus, it shares the risk, right? It's a joke. All right, gabapentin, Neurontin, no significant lab-related issues. Stop! You want to quit? We're almost done. We just got a couple little things now. Okay, gabapentin, no big thing, nothing. You don't really have to do a whole lot for that, okay? The selective norepinephrine reuptake inhibitors, agitation. Okay, fever, agitation. Got to do something with that R. Harm. Oh, hyperthermia, autonomic instability, delirium, and rigidity, myoclonus. Harm. That's hyperthermia. This is for serotonin syndrome? Okay. Is that right? Yeah. Okay. So it's harm. So you get the hyperthermia, which is a fever, the autonomic instability, which is the flushing and so on, some delirium, rigidity, and some myoclonus jerking, some rigidity. Yes, that's it. Harm. All right, great. Rigidity, myoclonus, autonomic activities. I like that one. That's a good one. Thanks. Thank you for that, Ken. Let me get, I think we only have a few more little things here. Blood pressure is the big issue with venlafaxine, Effexor, and Prestique. And you can get this syndrome of inappropriate antidiuretic secretion, so you have to watch for that. That's the hyponatremia issue. What do we got here? Practical blood pressure again. Oh. blood pressure elevations with duloxetine, Cymbalta, practical, just check the baseline, watch them. Pre-treatment with the SNRIs, BP, that about a heart rate, urine pregnancy tests, and so on. Regularly take the blood pressure and heart rate during treatment. Let's see if there's anything else. Trazodone, there is an issue with trazodone. There's Desiril, there's priapism. That is not dose dependent, by the way. The therapy is greatest, it's greater risk at early on. Does Nevada have a bill for prescription? That's a great question, does it? Clinical implications, warn them. All right, we're almost done. Want to monitor where you get anybody that you can, but it's hepatic complications. It's known to cause liver failure. What do we got going on here? Putting together our team now. No, oh, good, Joe. Hope you guys can do something. We need another state. Not that I have heard of, and I work with a psychiatrist who practices there. He did my supervision. Okay. You shouldn't wait for somebody else to do it. You should do it. Or anything else? Pre-treatment, urine pregnancy test. New Mexico or Louisiana. Commuting. That's a long commute. We're trying here in Hawaii. Great. New Jersey is close. Wonderful. Anybody from Illinois? They're supposed to be close. I'm in Montana and we still have my license, and VA is really the next place to try. We're trying indeed for West Virginia, Virginia, right? Oh, you're trying to get into the VA, Romano? New Mexico, not LA. Yeah, Veterans Administration. My understanding is there was a woman at the top of the VA that was fighting that. California is doing some groundwork. California probably will be. It's so huge, that's why. Okay, I think we're done with all these slides. The last you can kind of look into yourself. There's nothing great there. I think they're happened here in the past. I don't think the only states now are just Louisiana and New Mexico. When California goes, so will U.S. That's why it will be lots of resistance. The American Psychiatric Association is housed in Chicago, so it's tough there. Yep. It's really tough anywhere. You just have to really be politically savvy and get a good lobbyist and really fight hard. Guam has it. I think they have somebody actually now finally prescribing there. They've had that ability to do that for a while. Okay. In the sample test questions, Alzheimer's, there is a reference to blockade of the central cholinergic causing age-dependent learning impairments. It's a weird question. What is age-dependent learning? I'm trying to go backwards and understand that statement. Is age-dependent learning normal aging? Memory, normal aging. So reference to blockade of the central cholinergic. I don't know. That's a hard one. I don't know what that really means. What about a toxic level of Depakote? You're dizzy, tired, dysfunctional, essentially. You will complain of dizziness, though, and real serious fatigue. But I don't know about toxic levels of Depakote. Haven't had that experience yet. It is my sample questions. Those really are not mine. Those are things I've gotten from other people. I'd have to go back and look at that. Do you remember which question it is and where it is? I thought that was a PEP question regarding toxicity. There might be. You just have to look at that. So here's what you do. Read those chapters. Look at other questions. Look at the more detailed, harder questions, like in the book itself. And then look at those that Muse has put together. There are a bunch of questions in there. Most of those are in the back of mine. Sample questions 1, question 7, sample questions 1, question 7. Oh, you're pulling it from that list of those other 3 categories or 3 sections there. Is that where you got that from, Anthony? I think that's Muse's stuff, actually. Somebody gave it to me. Do you like the sample test CD that comes with Muse? I haven't looked at those, but I suspect they're pretty close to the ones that I have in there that you guys can load down, because I think that's where they're coming from, as I recall. Thank you, Doctor, for your time and expertise. Thanks for the review. You guys, you can pass this test, but really pay attention to those couple books that I told you to, okay? And you'll be fine. Take care, all of you. Good luck, huh? Let me know when you pass, all right? Just send me an email. It'd be nice to hear that, okay? Take care.